I practice at the Icahn School of Medicine at Mount Sinai. I was hired to treat persons with spinal cord injury. I do a bit of everything now. I find myself in the ICUs, doing consults on a variety of diagnoses, and still on the inpatient unit doing traumatic brain injury, other brain injuries, and spinal cord injuries. Some outpatient neuro rehab as well. So historically, there are a few intensive care units that you might find physiatrists. Trauma units, burn units, neurological units. Well, I find myself in all of them. Transplant, surgical, cardiac, whatever 8 or 9 and growing intensive care units exist at Mount Sinai. And that's had a trickle-down effect to our inpatient rehab units. My work in the ICU is growing. When we started seeing patients in non-traditional ICUs, meaning non-neuro, non-trauma, it was under the auspices of just early mobilization. There was some data coming out of Iowa and Chicago, and especially Johns Hopkins with Dale Needham there. And there was data that suggested from a hospital perspective it would be important to decrease length of stay, to early mobilization. And there was also data to suggest, a lot of great data to suggest that people did better. Their return to work at 1 year was better. Their discharge from being independent from an ADL perspective at discharge from hospitalization was better. All the things that you would want to know as a physiatrist that you don't always think about in an ICU setting. But there are a lot of other things that are coming up. You know, there's ICU delirium, there's PTSD-like symptoms that arise. And so and the more that I work in the ICU, the more it feels like what I was trained to do on any inpatient rehab unit. So we have team rounds there. They run similarly. They run much faster and more often because there's a lot of turnover. But the whole idea is the same. So we have our ICUs talking about disposition. We have our ICUs making mobility level goals. And we have delirium teams. We have all kinds of other things that have grown from what started as a basic idea. So I think the answer is complicated and it changes day to day. But certainly there's a lot in all these kind of new populations to be done and explored, which is exciting. When you start working in an intensive care unit, the culture that exists is variable. And so when I still remember a lot of the early interactions I had, I was a brand new attending. So I was just learning how to deal with myself. And you walk up to the director of the surgical intensive care unit and you tell them that they can ambulate this person that's ventilated, maybe on a pressor. Not ambulate, say mobilize. And they say to you, they may say to you, no way, or how can you guarantee nothing bad is going to happen? Or there's this kind of certain interactions, they're turf. So part of the process and part of the way you add value to the team is to forge relationships, earn trust, which takes time and effort and showing up. I think I had something happen recently, which was the way that we're structured, and every hospital is structured differently, but I think this is becoming more common. You know, the surgical ICU, just use the same example, they're housed in the Department of Surgery, but there's a separate kind of institute where there's one person in charge of all the ICUs. So that's where our process lives and where everyone kind of reports. So I had that person tell me recently, not even a couple months, it's been within 2 months, how more fulfilled they're feeling now, thinking about all these things that they're thinking about now, mobilization, disposition, what happens next, what are we really doing for our patients here? And so it takes time. That took a solid 5 or 6 years. But you see, I think that when people finally buy what we're selling, pick up what we're putting down, it's so easy to remember maybe why you went into medical school to begin with. I'm certainly partial, but I have never met anyone when they give physiatry a chance, and sometimes you just have to be pesky about it, that they won't really buy in or understand and connect to what it is that we do.